Hello, everybody. This is Dr. Hamid Elamir. I am the host of podcast with Dr. E. At this podcast, I sit with the world's experts in health, education, and community development to talk about current health challenges and ask them to share their experiences, knowledge, and thoughts with all nations across the world, especially the developing countries, so that we can learn from experts across the globe. Without further ado, let me introduce you to my guest today. Today, I have an amazing guest, a seasoned public health professional and a very humble physician, as all physicians should be. Despite his hectic and busy schedule, he decided to share his precious time with us and updates us with the current situation, COVID-19 in New York City. What are the next public health steps? How can other states and the rest of the world learn from New York City? Ladies and gentlemen, Dr. Tyler Evans is with us virtually on the show today. Thank you for being with us, Tyler.
Thanks, Amit. Pleasure.
Dr. Tyler is an MD, MS, MPH. He's also an HIV specialist and currently serves as the Chief of Medical Officer, CMO for the New York City Office of Emergency. He was previously the CMO for the county of Santa Cruz, California, Health Services Agency. So thank you very much, Tyler, for all your efforts. Let me start with a personal question. What made you decide to work in the epicenter of COVID-19 during the most difficult times here in New York City?
So that's a good question. I was the chief medical officer for a county health department in Northern California, and I was given the opportunity to coordinate on a CDC and DMAT program that was looking to quarantine and isolate crew and passengers from the Grand Princess. So it was sort of one of the first sort of operations where Americans were actually sort of isolating and quarantining, two very different concepts. And so, I consulted on it and, learned a great deal about how to use what's now described as alternative care sites, such as hotels, gymnasiums, schools, tennis centers, warships, and provide care for disaster management, whether it's public health emergencies or coastal storms or whatnot. So while working on that project, I was then recruited to work at the Billie Jean King Center, which is where the U.S. Open actually is held, where any sort of tennis fans would have seen Serena Williams or some of the greats playing there. Well, it turned out that was a good place to build a field hospital. So we had 470 beds, including 20 ICU beds, and I was one of two infectious disease consultants there. And so, we seeing a lot of patients, but interestingly, the occupancy really never exceeded 40 or 50 patients, despite. And I was recruited to work as the chief medical officer for the city Office of Emergency Management, and I saw that as a great opportunity to really help folks in need, particularly vulnerable populations. And just kind of rewinding 4 or 5 months ago, I never really thought I would be here. My background's in infectious disease and tropical medicine, and I've worked on programs setting up isolation quarantine programs in Sierra Leone and South Sudan and Congo. But I never thought I would be doing that in the United States, in New York. And I guess when I was in Northern California, kind of in my sort of blue sky operation, focusing a lot on vulnerable populations, homelessness, substance abuse, LGBTQ, migrants, particularly refugees and asylees. Nothing sort of that meets the current sort of magnitude of the issues seen with COVID. And when I went out to New York, my wife is actually 8 months pregnant. So she was about 4 or 5 months pregnant at the time. She was naturally pretty concerned about me going out to New York. Now, California had the highest spike to begin with. But the numbers in New York just continue to climb, and I realized that I've trained my entire life to manage situations like this. So it made a lot of sense for me to go out there. And I guess if this epidemic were taking place anywhere else in the world, I would be there. So there was a call to action, and I knew that in 5, 10, 15 years, when folks are reviewing or revisiting what we did during this sort of unprecedented pandemic, I wanted to be right in the middle of it. And here I am.
I wouldn't doubt you front lines of major diseases outbreaks around the globe. And this hard time that the U.S., especially here in New York, needs you. And it's such an inspiring decision that you made for so many others. And thank you for everything you do. New York is known as the city that never sleeps. Businesses, health services were unprecedentedly closed, and some are still closed. Probably most are still closed. But as a health professional, I believe it's courageous frontliners, and from physicians to nurses and other health professionals and food supply chains to save lives and health and help the rest of the New Yorkers stay safe at home. Tyler, you and your colleagues have been saved lives, gave people care and hope. Could you tell us what has been done so far, and at which phase is New York City in terms of controlling coronavirus?
Yeah, so we're currently in phase 1, and this is our second week of phase 1. Now, different phases mean different things to different cities. Mm-hmm. In terms of the context of New York, what that really means is sort of expanding essential services, businesses, construction. Of course, emergency services were always open, and critical services. And it's interesting when you look at the definitions of critical versus essential, they're slightly different. So phase 1 is essentially kind of expanding the essential operations in the city. Critical operations were never shut down. What that means is that there's going to be more contact with other folks. I mean, if anybody is familiar with New York City, they know that New Yorkers don't like to be told what to do, and they're tough. New Yorkers, yeah, they're tough. They are. They have it in their heads what they want to do, and they don't like to be told no. So it's challenging to keep a city of over 10 million people socially distancing at home. Particularly now it's summertime, people want to be out, right? Apartments are a little bit constrained. So phase 1 really should be relatively limited in terms of the services that are available. A lot of the businesses are now starting to create sort of a sidewalk, order or curbside walk up restaurants and bars where you can kind of take a drink or take a sandwich or whatever and sit at a park bench or whatnot. So they're kind of increasingly sneaking past what the city's boundaries are meant to sort of withstand. But it's just a part of being in the city. So I guess what I mean to say is the fact that it's in phase 1, it feels more like a phase 2. Mm-hmm. But having said that, we are still seeing a lot of folks that are appropriately socially distancing, wearing their masks, or staying at least 6 feet from one another. And that's an important point that I should bring up. Mm-hmm. There's a lot of misunderstanding about the concept of social distancing, right? We've never really heard of that before COVID, right? Of course, we've always heard about, for the medical community, we've heard about infection prevention and control. Yes. But social distancing is a new concept. COVID is spread through respiratory droplets, right? Mm-hmm. It is not an airborne disease, despite all this popular science that comes out. It is not an airborne disease. Mm-hmm. If there are aerosolized procedures, like bronchoscopies or people getting tubed, vented. That's a different scenario, and it is possible for the virus to live in the ambient environment a little bit longer.
Right.
But in a normal non-aerosolized sort of environment, it is only spread through droplets, and typically CDC precautions were always 3 feet. So it was really never 6 feet. It was always 3 feet. And the most important thing was source control. So the reason why we're wearing those masks is because it's not necessarily because of protecting themselves against other people that are sick. It's protecting themselves if they're asymptomatic from spreading it to other people, right? In terms of the viral shedding.
Yeah.
So that part is important. But frankly speaking, if you are at least 3 feet, ideally 6 feet away from one another, you really don't need to wear the mask. If you are in kind of an open setting. If you're in an office setting or something like that, where you might be virally shedding on kind of common computers or whatnot, it's not a bad idea to do that. So there's, we got to get to a point where we start to, we can live again, right? In a harmonious society that uses evidence-based infection prevention and control without scaring the population. And that's a very challenging balance, right? Because sometimes if you tell people too little, they might run with that and say, oh, well, this isn't that important. And then if you overstate risk, then you run the risk of creating sort of fear amongst populations. So having that balance is important, and we've got to live again, but we've got to live in a way that gives us the appropriate precautions we need. So yeah, we are in phase 1, and we plan to be in phase 2 in early July. But again, it feels like we're in phase 2 already, to be honest.
Oh, okay. So just for our audience to be clear, there are like how many 4 phases, and is this called the New York Forward Plan? That's the same thing.
Yeah.
Okay. So if you can briefly talk also, like you mentioned it, like what would be the next steps, the phases, like for phase 2, 3. I think that a lot of people are desperately waiting for going to restaurants. Like myself, I live in New Jersey, but I always have enjoyed New York and their diverse cuisines. But I think that could be all the way to the last phase.
Well, I mean, phase 2, and to be honest, the script is still being written as we move forward. So, I can't tell you that what we currently think the certain phases are going to be is not going to change next week. So we keep on saying, working in emergency management, we build the plane as we're flying, right? So, and a lot of the decisions in City Hall, rightfully so, have had to be made almost kind of spur of the moment, by virtue of it being an emergency. So phase 2, I mean, you're gonna have more openings, more relaxation of essential businesses. Essentially, the idea is just to expand it further. There are discussions about creating kind of pedestrian only areas on certain streets. Where they would kind of space out tables, and you could kind of you could order your food or your drinks, and then sit down at a table where there are no cars, and that allows again the social distancing or the spacing to be taking place more responsibly. The balance with that is typically there are a lot of ordinances with if you're drinking some wine, a beer, a cocktail. There are rules and regulations when it comes to drinking those in public. Correct. So the public health departments are now working on relaxing some of those, kind of typical laws. So that's the idea with phase 2. It's expanding the definition of what essential services are, and then creating some of those kind of, in terms of entertainment, creating some of those kind of pedestrian only streets, mostly around like the village and whatnot. And then once you essentially get up to phase 3,
Yeah.
it would be basically kind of opening up the majority of those other sort of businesses, and
Hmm.
then finally phase 4 is just kind of opening everything up. And there's an association with the phases. I call them waves, right? Like sort of regulated waves,
Yeah.
that increasingly allow people to work, to make a living, but also there's an association with the healthiest of the populations too. So in theory, and this is what has been done in, say, Germany and some other countries,
Yeah.
where they're just increasingly allowing fitter people to come outside, and if they do get sick, right, 90 to 95% of folks that are infected with COVID are going to have mild, moderate, upper respiratory infection.
Yeah.
Might last a little bit longer than your typical upper respiratory infection, but should not need hospitalizations, right?
Hmm.
It's the vulnerable populations that are truly the
Yeah.
most impacted. Usually a number of comorbidities, but
Hmm.
vulnerability, I think we'll talk about that a little bit, can
Hmm.
have a number of different
Yeah.
components. So we want to keep the vulnerable populations as separated as possible and have them be at the final phase.
Correct. Well, thank you again so much for the clearing, the making that very clear for us and for New Yorkers as well as for the states that are the neighboring states, and we are interconnected.
Yeah.
This actually leads me to the next question that the tri-states, namely New York, New Jersey, and Connecticut, are intertwined and interconnected from different aspects. What are some of the public health challenges at the tri-state level, and what can be done by residents of these states to help overcome the fight against COVID-19?
Political restrictions and kind of working together has been challenging, because
Hmm.
it's unclear. Sometimes it's unclear from a public health standpoint,
Hmm.
if the city or the state has primary jurisdiction.
Hmm.
I remember my primary specialty is working with HIV
Hmm.
and tropical medicine, and that was the other acronym that you were looking into, was the Diploma of Tropical Medicine and Hygiene. So yeah, I mean, when it comes to HIV, for example, if folks are seen, for example, in a New York City hospital, but they live somewhere else out of state, then New York City would have the jurisdiction over that patient versus the state.
Hmm.
So that, from an infectious disease standpoint, sometimes that matters, where you're actually being seen versus what your residence is.
Correct.
Yeah, so there, and because the tri-state area often acts as one,
Hmm.
functionally, that's also created more barriers, because you have variable sort of mayors within different states, and
Yeah.
I actually talk about this often. I think the silver lining to COVID is that in the absence of strong national leadership, what we have are a lot of states that are rising up along with cities, and
Hmm.
they are managing the issue on their own, right? And I think that the U.S., by definition, the United States, needs to have a better network or
Hmm.
forum or consortium between different state governors and city mayors,
Yeah.
almost kind of like the mega city or super city sort of mayors,
Hmm.
should be able to kind of reach across the aisle and
Hmm.
connect with each other in solidarity to get
Hmm.
things done, right? So
Hmm.
if in LA they were
Yeah.
down on ventilators or
Hmm.
PPE or whatnot, Garcetti can call up De
Hmm.
Blasio and say, hey, could
Yeah.
we need to really reduce a lot of these restrictions.
Hmm.
And from a medical standpoint, I think the fact that we actually have required state medical licenses, required in each state, and having to go through that entire process
Yeah.
with a different medical board in a different state, just doesn't really make a lot of sense.
Yeah.
In times of emergency, right? For New York, we removed that barrier. So anybody coming in with an active medical license in the United States could come in.
Mhm.
So if we could do it in a time of emergency, I think that we could
Yeah.
open that up
Mhm.
in a time of time of peace or blue
Yeah.
skies,
Yeah.
and really allow the medical community, allow the public health community to really intersect and create a sense of uniformity, standardization when it comes to evidence-based procedures, and sharing resources, and again working along with city and state governments.
Yeah.
I think we're going to have a lot of changes to the way that government is practiced.
Well, great. Those are very important points that you just mentioned, especially during a crisis time. Barriers shouldn't, exist at any time, but especially during this hard time. And I was even thinking about New York City that has been hit hard, and during those really tough times that we were asking for help from the rest of the country. There are also even international physicians who are here in the U.S. And they are either preparing for their board exams. They actually live here in the U.S. They are U.S. citizens and mostly, but their licenses from other countries or their countries of origin, and those could be also potential help for such crisis time, and of course any other time to help people and save lives. I'm glad that we are on the other side of the curve now, and that is all because of the joint efforts from across the nation. And again, I really appreciate the tough work, the hard work that every one of you and all the you know health professionals um, and frontliners were doing.
Mm-hmm.
Um, so the time is actually getting close to the end of this podcast. You had worked in Africa during Ebola outbreak. Considering some of the social determinants of health in underserved communities of New York, which might be similar to the developing countries, and there are vulnerable populations in every parts of the world. And my audiences are both here in the US and across the world. How can other nations, especially those experiencing the peak of coronavirus pandemic, such as in Afghanistan, learn from New York City and your own experiences from a community health point of view?
Yeah, it's a great question. So, really, what I was kind of alluding to earlier was that when it comes to COVID, and when it comes to really a lot of infections, it's often vulnerable populations that are going to be the most susceptible to not only just infection, but to sort of adverse progression of the disease.
Mm-hmm.
And in terms of the former, the reason why folks may be at increased risk, it might be because of their living conditions. It might be because of
Mm-hmm.
they're immunocompromised, and so they're more likely to actually get to get sort of infected. When we're dealing with vaccine preventable illnesses, folks might not have access to the appropriate vaccines.
Mm-hmm.
In countries throughout the world, they may not have access to appropriate sanitation, hygiene, nutrition, et cetera, and as well as basic primary care and mental health services to ensure that people are strong.
Mm-hmm.
So that's what when we talk about the social determinants of health,
Mm-hmm.
that really influences populations of vulnerability and populations of strength.
Yeah.
And unfortunately, those social determinants are largely associated with compositional factors like
Mm-hmm.
race, gender, gender
Mm-hmm.
identity, sexual orientation, geography, immigration, etc. I think that these inequalities that existed
Mm-hmm.
worldwide have and it's there's we make the distinction between the global north and the global south.
Mm-hmm.
There are certainly massive inequalities that take place between these regions, but
Mm-hmm.
even within the global north, even within the United States, we have a
Mm-hmm.
great deal of inequalities, including New York City.
Mm-hmm.
And when we look at the most vulnerable populations here, we're really looking at the homeless or housing insecure, those that are suffering from substance use, those that are, migrants, particularly political migrants, folks that are living in multi-generational homes,
Mm-hmm.
folks with food insecurity, and mental health issues in
Mm-hmm.
this country. So we're really looking at, 4 or 5 major groups. And in terms of what we've seen, those folks have been certainly the most impacted.
Mm-hmm.
And whether you're seeing that in New York City, or whether you're seeing that in Pakistan or Afghanistan
Mm-hmm.
or Sierra Leone or Congo, I was working on Ebola in Sierra Leone, and I was working in the poorest province in the country. Now, Sierra Leone at the time had the lowest mean survival rate in the world.
Mm-hmm.
It had a mean survival of 48 years. Now, there were outliers that skewed that data, mostly because of infant mortality rate and because of
Yeah.
the war. But 48 years, and then I was working in the poorest province in that country. So when I was working there on Ebola,
Mm-hmm.
we had just piles of dead bodies, just
Wow.
piled up in hospitals, because nobody really knew what to do with that.
Wow.
When it comes to other regions in Africa, like including DRC, Democratic Republic of Congo, the same applies, right? We have a
Yeah.
country replete with minerals, with access, but you have massive inequalities, and the vast majority of the country is living in abject poverty and misery because of the complex humanitarian emergency and war. Same goes, for your audience here, in Afghanistan, and there are differences. There are areas of great wealth, and there are great areas of great poverty, and war-torn regions. And we know that the infections and the general public health issues that exist in those latter populations, those vulnerable populations,
Mm-hmm.
which are socially determined, are the ones that we really need to focus on.
Mm-hmm.
So that's our job, really, right? When it comes to, I think COVID just gave us an opportunity. The silver lining is it gave us an opportunity to really highlight some of those inequities, some of those disparities that we know have existed
Yeah.
for decades, for centuries, but this
Mm-hmm.
is really highlighted. Now the whole world is listening constantly.
Yeah.
And we knew that these, I work a lot in South Asia and, Near East and Sub-Saharan Africa. I've been aware of these, but
Mm-hmm.
most folks living in the global North are just not aware of it. It's not a part of the general lens that the media basically sort of portrays
Yeah.
about the rest of the world. And so COVID has now done that. COVID has now basically essentially not only highlighted all of the issues, but they have amplified some of these health disparities. And I think now there's going to be a lot more funding to help kind of to focus on some of these inequities, and bring some of the
Mm-hmm.
parity and equity that the world really needs in order to prevent the next major pandemic.
Mm-hmm. Well, great. Very informative points there, especially for your experiences in developing world and in Africa, and fighting Ebola, which pretty much from the same family of virus, is really powerful, and it helps not people here in the U.S. and what you're doing, but also nations across the world, especially Afghanistan and developing countries. And you know, eh, although the these like the United States with developing countries are economically and technologically and culturally different, but as you said, the vulnerable populations exist everywhere, and we can definitely learn from New York City to to fight against COVID-19. And I believe, like, the way that we think, we see as that the virus, who is the most vulnerable population to, when it comes to COVID-19, is the elderly people because of their, health issues. Same thing is true when it comes to the underserved communities and underserved, economically compromised, and they have, fragile health systems, which puts them actually at a higher risk of fighting the COVID-19, and that makes it more difficult for them. So thank you very much for your time, and it's been a pleasure. I really appreciate that, despite of your hectic schedule, you give us some time today to talk situation of COVID-19 in New York City, and for the rest of the world to learn from your experiences.
No problem.
If
Pleasure.
I didn't even ask you this, but all of a sudden, just I'm gonna read in this with the great quote that is actually I read it in your email when I was corresponding with you. Um, it says that as disease is so often associated with poverty, physicians are the natural attorneys of the poor. How powerful is that? And it's by Rodolphe Virchow.
Virchow, yeah, known for the Virchow nodes as well.
Great, that is a very powerful quote, and thank you again very much. And for our audience, thank you again, everyone, for listening, and please stay tuned with the podcast with Dr. E for more amazing guests to come and talk about the current health situations. Thank you again.
Thank you. Tashkor.
Tashakkur.